Thank you so much. It's 9 o'clock. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everyone. Welcome and thank you for joining the webinar. And I'm really grateful to Dr. Mehreen Khan for giving her time to give us this webinar and teaching. So let me take a minute to quickly introduce her. Dr. Khan is a graduate of King Edward Medical College. She initially did her training, did MCPS and FCPS in hematology. And later on, she went for further training and did her training at King's College Hospital in London in 2011 and had been serving as the Armed Forces Bone Marrow Transplant Center in Rawalpindi since 2012. And now she's serving as a professor of hematology and bone marrow transplant physician. She has worked at the MD Anderson during a visitors training program by ASH and ICML preceptorship program. And she has a special interest in MPNs, CML, myelodysplastic, and myeloid malignancies. So without further delay, I will invite her to give her a webinar. Thank you so much.
Thank you very much, Faiz Bhai. I think you can hear me now.
Yes, I can hear you. We can hear you.
Thank you very much for a very kind introduction. I don't even deserve. So without any further delay, we would like to start with the task. So my task today is to discuss the role of somatic mutations and treatment strategies in Philadelphia negative myeloproliferative neoplasms. I would like to start with a very pertinent verse from Holy Quran. Inna Allaha la yughayyiru ma biqawmin hatta yughayyiru ma bi anfusihim. Indeed, Allah will not change the condition of people until they change what is in themselves.
Sorry, can you please share the screen? We can't see your slides. Can you please share the screen?
Okay, just 1 minute. Is it visible now?
Yes, go to slide mode, slideshow mode.
Thank you.
Yes, good now. Please go ahead.
Yeah,
so the somatic mutation and strategies for Philadelphia negative MPNs. And I was mentioning a very pertinent ayat from Surah Al-Ra'd, that is, Inna Allaha la yughayyiru ma biqawmin hatta yughayyiru ma bi anfusihim. Indeed, Allah will not change the condition of people until they change what is in themselves. And it is very beautifully translated by my inspiration and inspiration of all Pakistanis. खुदा ने आज तक उस कौम की हालत नहीं बदली, ना हो जिसको ख्याल आप अपनी हालत के बदलने का. So I would like to apply these verses for the establishment of mutational analysis, especially for MPN, in the tertiary care centers of our country. So I don't have any disclosures. Coming to myeloproliferative neoplasms. I think the audience mostly is postgraduate residents, so I have kept it very simple. Myeloproliferative neoplasms are defined as a group of chronic hematological malignancies, which are characterized by the clonal hematopoietic disorders resulting in increased mature cells, polycythemia vera, that is red cells, platelets, essential thrombocythemia, and fibroblasts, that is primary myelofibrosis. When we did training back in 2001, myeloproliferative neoplasms included at that point in time chronic myeloid leukemia as well. But gradually, BCR-ABL positive CML was made a separate entity, and BCR-ABL negative MPNs are now what we call Philadelphia negative MPN. Either there is granulocyte monocytic proliferation resulting in chronic neutrophilic leukemia or eosinophilic leukemia, or there is megakaryocytic erythroblastic proliferation resulting in increased red cell, that is PV, or increased platelets, that is ET. Megakaryocytes produce chemokines, cytokines, and growth factors, resulting in prefibrotic primary myelofibrosis and overt primary myelofibrosis. You can see very beautiful morphology of bone marrow here when we see trilineage hematopoiesis, that is panmyelosis, very small mononucleated megakaryocytes are visible. Increased erythropoiesis and myelopoiesis. This is morphology of PV. And you can see here in ET, large staghorn appearance megakaryocytes with loose clustering, that is ET, and increased reticular fibrosis, that is primary myelofibrosis. So Philadelphia chromosome negative MPN, ET, and PV can transform into secondary myelofibrosis, 10 to 20% of them. Both primary as well as secondary myelofibrosis can then transform into AML. I hope there's no problem in listening this voice.
Yeah, we can hear you, no problem.
Okay, thank you. Thank you. So when we see overview of MPNs, in 2022, World Health Organization classified it once again, and with more emphasis over molecular markers. That is genus-associated kinase, JAK2, V617F, where valine has a point mutation and it's replaced by phenylalanine, calreticulin, and c-MAPLE, that is myeloproliferative leukemia gene. All these MPNs have very overlapping features. When we see them in clinic, most of them are coming with either thrombosis, bleeding, fatigue, and then there is progression to myelofibrosis and AML. So look at the driver mutations of myeloproliferative neoplasms, which drive them. And most important of them is JAK2 V617F. 95% of PV are JAK2 V617F positive. And 50 to 60% of ET and primary myelofibrosis are JAK2 positive. When we come to calreticulin and c-MAPLE, 20 to 30% are ET are positive with calreticulin and MPL in both ET and PML. And here is we can see the landscape. So you see in PV, more than 95% are JAK2 V617F positive. There is a very few percentage, 3 to 4% JAK2 exon 12 to 15, and 1% is JAK2 unmutated. The landscape of ET and primary myelofibrosis is very similar to each other. 50 to 60% are JAK2 V617F positive. Almost 25% are calreticulin positive, both CalR1 and CalR2. Less than 10% are c-MAPLE positive, and around 10 to 15% are JAK2, CalR, and c-MAPLE unmutated. So let's see how these mutations work. These germline predisposition might be present in the form of MECOM, TERT, but they don't cause any visible dysplasia. However, when there is clonal driver mutation in the form of TET2 or DNMT3A, this goes into pre-CHIP phase, that is clonal hematopoiesis of indeterminate potential. And then with MPN driver mutation, that is JAK2, CalR, and c-MAPLE, they start a CHIP phase, that is clonal hematopoiesis of indeterminate potential with mild dysplasia in the morphology and sometimes cytopenias. This then transformed into MPN phase. And with MPN phase, we don't know whether this is 1 decade or 2 decades. There are certain mutations which are associated with progression of MPN and to transformation to AML. That is ASXL1, EZH2, IDH1 and 2, SRSF2, SF3B1, U2AF1, NRAS, KRAS, and TP53. We transplanted one patient with U2AF1, and recently I've admitted a patient who was previously diagnosed with triple negative myelofibrosis, but genetic testing revealed TP53 homozygosity. So the diagnosis has been changed to fibrotic MDS. So this is the importance of these mutations in diagnosing and treating these patients. So this is JAK-STAT pathway, which is the main culprit and proliferation of the cells in myeloproliferative neoplasm. It's a bit complicated. Let's come to this one. It is a bit more easier. So whenever we talk about myeloproliferative neoplasm, there is GM-CSF, that is granulocyte monocytic colony stimulating factor, with TINs and TERTs. In tins, you have erythropoietin, prolactin, and thrombopoietin, and leptin. And in TERs, you have interleukins and interferon. These are attached to the receptors, and these receptors then cause phosphorylation of Janus-associated kinase. Janus-associated kinase cause phosphorylation of these receptors as well as phosphorylation of stacked pathway, that is signal transduction and activation of transcription. There is dimerization of STATs, and then STAT go to the nuclei, causing increased transcription of the DNA and increased proliferation of the cells. So there are many co-occurring mutations in JAK2 positive MPN, as we have already discussed. ASXL1, which is associated with inferior survival, progression to myelofibrosis, or acute myeloid leukemia. The prevalence in JAK2 positive MPN is 20 to 30% of primary myelofibrosis, and 15% of PV or ET have ASXL1. Then coming to TET2, is associated with earlier disease onset, variable impact on the thrombotic risk, and 10 to 20% of JAK2 positive MPNs have TET2. DNMT3A is linked to clonal dominance and progression, as in found in 5 to 10%. SRSF2 is a strong predictor of leukemic transformation and myelofibrosis. It is 10 to 15% of PMF specifically have SRSF2. U2F1 correlates with anemia, thrombocytopenia, and poor prognosis, and is found in 5 to 10% of MF. TP53 is therapy resistance, and AML evolution is more in TP53, but it is rare in MPN. It's around 5%. And IDH1/2, we all know that is associated with AML transformation in 3 to 5% of MPNs. So coming to these Philadelphia negative MPNs individually, let's start with polycythemia vera. Very simple case minier. A 65-year-old male presents with persistent headaches, facial redness, and pruritus. Physical examination revealed ruddy cyanosis and splenomegaly that was 2 centimeters below the costal margin. Laboratory findings revealed hemoglobin 18.5 gram per deciliter and hematocrit 55%. And platelet count was 415 to 10 raised to power 9. Diagnostic workup include blood complete picture, which I've already discussed. Then JAK2 mutation testing confirms V617 mutation positivity. Bone marrow biopsy demonstrates pan-myelosis with megakaryocytic hyperplasia and atypia. Erythropoietin levels were subnormal, and secondary causes of polycythemia were excluded. It is very important to exclude secondary causes. We work in an Armed Forces Institute where we get many soldiers who come from high altitudes, 7,000 Gilgit-Skardu and 12,000 Siachen, when they're having secondary polycythemia. So it is very important to exclude secondary causes of polycythemia before labeling PV. So this case is JAK2 V617F positive. So how do we manage? Phlebotomy to maintain hematocrit less than 45%, low-dose aspirin for thrombosis prevention, and then come hydroxyurea or ruxolitinib, that is JAK2 inhibitor, which are considered for high-risk patients. We'll discuss shortly what is high risk and what is low risk, or those who are refractory to phlebotomy. So key clinical correlation in this case are JAK2 mutation is present in 95 to 98% of PV, as we have discussed, while exon 12 to 15 mutation of JAK2 are there in almost 3 to 4% of the cases. Thrombotic risk correlates more with JAK2 allele burden. Unfortunately, in our setup, allele burden is not present, but we are trying to have the facility established. Splenomegaly and leukocytosis are more prevalent in JAK2 positive patients. So coming to WHO classification, in 2008, the major criteria were hemoglobin more than 18.5 in men and more than 16.5 in women, with JAK2 V617F or JAK2 exon 12 mutation positivity. Both major or first major plus 2 minor criteria were required, and the minor criteria were bone marrow trilineage hematoproliferation, subnormal erythropoietin, and endogenous erythroid colony formation. And then came World Health Organization 2022, in which the hemoglobin was a bit lowered, that is 16.5 gram per deciliter for men and 16 gram per deciliter for women. Hematocrit more than 49% in men and more than 48% in women. Characteristic marrow features, that is hypercellularity with panmyelosis and megakaryocytic hyperplasia, was another major criteria. And JAK2V617F or JAK2 exon 12 mutation should be positive. So all three majors, or first major and second major plus a minor criteria, was required. In minor criteria, it is just erythropoietin subnormal. So bone marrow, now major criteria in WHO 2022, and endogenous erythroid colony formation was omitted from the classification, which was difficult to do. Coming to the symptoms, whenever we see these patients in clinic, we see them with all these four types of symptoms. Constitutional symptoms, that is fatigue, pruritus, night sweats, bone pains, weight loss, and sometimes low-grade fever. Microvascular complications, that is erythromelalgia, headaches, dizziness, visual disturbances, paresthesias, or sometimes TIA. And macrovascular complications, which include both arterial as well as venous thrombotic events. Myocardial infarction, unstable angina, stroke, peripheral arterial occlusion, or DVT and pulmonary embolism. Sometimes they have intra-abdominal vein thrombosis. We have seen mesenteric vein thrombosis. We have seen splanchnic vein thrombosis. We have seen portal vein thrombosis. And cerebral vein thrombosis might also be there. And the long-term complication of PV include secondary carcinomas. We had a patient with PV. She was a young girl, a daughter of a doctor, who developed ALL later. Long-term complications are splenomegaly and hepatomegaly as well, and progression to myelofibrosis, MDS, and acute myeloid leukemia is a possibility. So when we just stratify PV low risks are age less than 60 and no prior history of thrombosis. And high risk are age more than 60 or prior history of thrombosis. So European Leukemia Network guidelines recommendation about the treatment are that the low-risk patient aged less than 60 or no history of thrombosis should have therapeutic phlebotomy with daily low-dose aspirin. And in high-risk patient that is more than 60 years or history of thrombosis, cytoreduction is required. First-line cytoreduction is hydroxyurea or ropeg interferon. Ropeg interferon or interferon both are not currently available in our country. There was an era when hepatitis C treatment required interferon and it was available all over, but now it is very difficult to get it. Other than high risk, ELN also has indication for cytoreduction when there is poor tolerance to phlebotomy or frequent phlebotomy requirements. Whenever there is symptomatic or progressive splenomegaly or severe disease-related symptoms, or the platelet count is more than 1,500 or leukocyte count is more than 15 into 10⁹ per liter. In such cases, hydroxyurea can also be given or cytoreduction can be given despite being in low risk. And if you talk about second-line therapy, intolerance or resistance to hydroxyurea or uncontrolled or progressive symptoms and ongoing phlebotomy need requires second-line therapy, which is most commonly ruxolitinib in patients with advanced disease duration, moderately increased symptoms. Sometimes people select PEG interferon if it is available, and busulfan is very seldomly selected nowadays. And then there are clinical trial agents with the name of givinostats, not available in Pakistan. They are histone deacetylase inhibitor. Phase 1B and 2 trials have been done, resulting in complete hematological remission and partial hematological remission at 6 months in 80.6% of patients. Improved symptoms, decreased JAK2 disease burden, but the side effects includes diarrhea, thrombocytopenia, and azotemia. Then another clinical trial agent is ida-sunitolin, that is MDM2 inhibitor. Phase 1 trials have been done and overall response is 58%, but they are also associated with low-grade GI toxicity. So let's see what is intolerance or resistance to hydroxyurea. Resistance means when there is increased need for phlebotomy to keep hematocrit less than 45%, or increased platelet count more than 400, or increased WBC count more than 10, no reduction of splenic size by 50%, or no reduction of splenic symptoms despite more than 3 months at maximal tolerated dose of hydroxyurea, that is 2 grams per day. That makes 4 capsules. And intolerance is cytopenias, that is absolute neutrophil count less than 1 into 10 raised to the power 9 per liter, hemoglobin less than 10 gram per deciliter, or platelet count less than 100. GI toxicity, fever, mucocutaneous toxicity, and sometimes skin ulcers, even at the lowest dose to achieve either a PR or CR by ELN criteria. This is called intolerance. So resistance due to uncontrolled hematocrit and symptom is a key reason for switching from hydroxyurea to ruxolitinib in a US-based study. You can see here that the primary reason for hydroxyurea discontinuation in patients treated with ruxolitinib, there were 249 patients, 78% patient had resistance, 28% had intolerance to hydroxyurea. In 23%, there was patient's choice to switch over, and 4% had other causes. And reasons for hydroxyurea discontinuation due to resistance were hematocrit more than 45%. In 79% of the cases, 63% had symptoms. They couldn't tolerate hydroxyurea. 38% had leukocytosis, and another 38% had thrombocytosis. Hydroxyurea intolerance symptoms usually include nausea, vomiting, stomatitis, skin ulcers, and fever. We very frequently see nausea and vomiting and skin ulcers, especially on the legs. Early ruxolitinib initiation results in earlier hematocrit control and reduction in JAK2 V617 allele burden. According to Response 2 trial, you can see that median hematocrit level were achieved earlier, the lower level with ruxolitinib, this is the red one, and also the median JAK2 V617F allele burden was lower in ruxolitinib using patients. So coming to ET, essential thrombocythemia has a very characteristic appearance of megakaryocytes, loose clusters, staghorn appearance, but remember the marrow should not be hypercellular and there should not be reticular fibrosis before labeling ET. So let's have a very small case. Vinay, a 68-year-old woman presented with intermittent headaches, an episodic burning episode in her fingers, erythromelalgia. On the physical examination, spleen was enlarged with facial erythema. Laboratory findings showed hemoglobin 14.2, leukocytes 12 into 10 raised to the power 9 per liter, and platelet count was 780. Diagnostically, when we did JAK2 V617F mutation, it was detected. Allele burden was 35%. Bone marrow biopsy demonstrated megakaryocytic hyperplasia without significant fibrosis, which is a required criterion for WHO. Serum erythropoietin level was normal, excluding PV, and all the secondary causes of thrombocytosis were also not found. Iron studies were normal, CRP was normal. So another important thing is to exclude secondary causes of thrombocytosis. So this patient was treated with low-dose aspirin, initiated for microvascular symptom and thrombosis prophylaxis. Hydroxyurea started due to Halley's seizure, that is age more than 60 and JAK2 mutation. And there was no need of serial phlebotomies because it was not PV and hematocrit was less than 45%. So JAK2 V617F mutation occurs in 50 to 60% of ET cases, and it correlates with higher thrombotic risk, at least 2.5-fold increased risk versus CAL reticulin mutated ET. Sometimes there is extreme thrombocytosis that is more than 1,000, and in this case, we should check von Willebrand factor antigen, which is required, because it may paradoxically increase bleeding risk. So annual transformation risk to myelofibrosis is 0.5 to 1% with spliceosome mutation, that is SF3B1, which predicts faster progression to myelofibrosis. And this is WHO diagnostic criteria. You have found them in books, you have read them, you have memorized them. Major criteria include platelet count more than 450 to 10 raised to the power 9 per liter. Bone marrow biopsy showing proliferation mainly of megakaryocytic lineage with increased number of enlarged mature megakaryocyte, hyperlobated nuclei, staghorn appearance, loose clusters, and not having fibrosis or having less than grade 1 fibrosis. Not meeting WHO criteria for BCR-ABL, 1 positive CML, PV, or MF, myelodysplastic syndrome, or other myeloid neoplasm. And presence of JAK2 V617F, KLR, or MIPL mutation. And minor criteria is presence of a clonal marker or absence of the evidence of reactive thrombocytosis. Diagnosis of ET requires meeting all 4 major criteria or first 3 major and a minor criteria. So what are the symptoms of essential thrombocythemia? They can be cytokine related, that is pruritus, bone pains, fatigue, constitutional symptoms. In my practice, I have seen many patients with severe bone pains, especially the young girls with ET. They come with severe bone pains. They have to use IV painkillers for controlling this pain. Then there can be vascular symptoms, that is headache, dizziness, numbness, low mood, and sometimes sexual problems as well. And disease evolution involves splenomegaly and constitutional symptoms. Micro and macrovascular thrombosis can be present, and disease transforms into myelofibrosis in due course of time or AMN. So from newly diagnosed to second decade, there are increase in symptoms, transformation, but it's important to follow the symptom burden, as even low-risk ET can have a pronounced burden of the symptoms. So international prognostic scoring for ET risk stratifies ET very well. A revised IPSET thrombosis score is JAK2 positive, adds 2 points and makes it high risk. High risk criteria, as we have already discussed, is age more than 60 or prior thrombosis with JAK2 positivity. And British Society of Hematology recommends that JAK2 positive ET patient, even lower than 60 with high risk CV cardiovascular features, should be considered for cytoreduction. So it is not hard and fast that the cytoreduction can be given only in high risk patient. It can be given in low risk patient as well with increased cardiovascular risk. And these are the IPSET criteria for essential thrombocythemia. Very low risk are age less than 60, JAK2 wild type, and no prior thrombosis. And in management, we just observe and give low dose aspirin unless it is contraindicated. And contraindication we have discussed: when there is acquired von Willebrand disease, aspirin usage is contraindicated. Low risk include age less than 60, JAK2 V617F positivity, and no prior thrombosis. We manage them with low dose aspirin. Twice daily can be given in cardiovascular risk, and intermediate risk are age more than 60, JAK2 wild type, no prior thrombosis, and cytoreduction therapy plus low dose aspirin is given unless it is contraindicated. High risk are age more than 60 with JAK2 positivity or prior history of thrombosis. Cytoreductive therapy should be given with low dose aspirin unless it is contraindicated. So how do we manage the symptoms? The goal of therapy is that the symptoms should be managed. There should be reduced risk for thrombosis or hemorrhage, and there should be delay in transformation. We should prevent the transformation. For all patients, cardiovascular risk should be managed. How do we do that? Aspirin is given. For those who are having microvascular disturbances or cardiovascular risk, JAK2 positivity, yes, cytoreduction. It is not necessarily given in low risk or low or intermediate risk. It is second line option is hydroxyurea or interferon. We do give anagrelide as well if it is available. And for high risk, it is definitely indicated to cytoreduce these patients with hydroxyurea or interferon. It's a very interesting slide. I took it from a conference in it was in Italy, Pavia. So JAK2 V617F mutant ET is high risk of thrombosis and risk of progression to PV is more. CALR mutant ET has high risk of myelofibrotic transformation, mainly associated with type 1-like mutation, and type 2-like mutation is relatively simpler. MPN mutant ET have risk of myelofibrotic transformation associated with acquired copy-neutral loss of heterozygosity of chromosome 1p. And triple negative ET is better, but sometimes triple negative ET is not ET, as I've already told that one of our patients had homozygous TP53 and turned out to be fibrotic MDS. Coming to primary myelofibrosis, Primary myelofibrosis was discussed in very detail 2 weeks ago by Dr. Haris Ali. However, I would like to just touch it for those who have not attended the previous one. So starting with the case is a 72-year-old male who presented with fatigue, early satiety, and weight loss. Physical examination revealed pallor, massive splenomegaly that was 17 centimeters below the costal margin. Laboratory findings were on peripheral blood film. We could see leukoerythroblastic blood picture with teardrop cells and 3% circulating blast. Hemoglobin 9.8 gram per deciliter, leukocyte 28,000, and platelets 110 into 10⁻⁹ per liter. JAK2 V617F mutation was detected. Bone marrow aspirate was done, and along with the biopsy, which revealed megakaryocytic hyperplasia with very dense reticulin fibrosis, that is MF3 on reticulin stain. LDH was elevated at 850 unit per liter, and cytogenetics revealed a normal karyotype. So how would we manage this myelofibrosis? Ruxolitinib is the drug of choice, especially for those who have symptomatic splenomegaly and constitutional symptoms. Unfortunately, it is available, but the price is not affordable for many of our patients. Transfusion support should be done for anemia or erythropoietin-stimulating agent. Dynamic international prognostic scoring system, DIPS Plus, is usually used to categorize as high risk, age more than 65, hemoglobin less than 10, and platelets less than 100. So the key clinical correlations are that JAK2 V617F is positive in 50 to 60% of PMF cases. It is usually associated with larger spleen size. Mean size is 17.8 centimeter versus a lower size that is 14.2 in wild type. LDH is elevated and which it is associated with disease progression. And 20% 5 years survival in high-risk DIPS plus patient is 20% versus 70% in low risk. So you see in low risk, the survival is 70%, and in high risk, the survival is just 20%. And these are the World Health Organization diagnostic criteria 2022. Major criteria include presence of megakaryocytic proliferation, atypia, and increased reticulin or collagen fibrosis, grade 2 to 3. Not meeting WHO criteria of ET, PB, BCR-ABL positive CML, MDS, or myeloid neoplasm, and presence of JAK2, CALR, or c-MAPL mutation. In the absence of these mutations, presence of another clonal marker or absence of reactive myelofibrosis. It should be absent. And the minor criteria, at least one of the following minor criteria should be there. Anemia not attributable to comorbidities. Leukocytosis more than 11,000. Palpable splenomegaly. LDH increased to upper normal limit of institutional reference range. It should be above that. And leukoerythroblastic plaque picture. So diagnosis of overt myelofibrosis requires meeting all three major and at least one minor criteria. And in our clinical practice, we see that these patients are those who are coming frequently with symptoms. PV and ET are relatively bothering the patient lesser as compared to primary myelofibrosis with larger spleens. So high-risk mutations are ASXL1, SRSF2, UTF1. We have already discussed. DIPS plus scoring incorporates karyotyping, transfusion need, and thrombocytopenia. And ASH guidelines are that about a JAK2 positive PMF with high-risk mutation, we should prioritize transplant evaluation earlier. Earlier, the better. So being a transplanter, I would always advise that if the patient is transplant eligible, we should work up for the presence of the donor. And if fully HLA matched donor is available, transplant should be preferred. However, there are many ifs and buts about availability of the donor, availability of finances, and so on and so forth. So this is DIPS plus and DIPS scoring. In DIPS, age more than 65, symptoms, WBC count, hemoglobin, and myeloblasts are included. And in DIPS plus, there are adverse karyotype and platelets less than 100, and RBC transfusion dependency is also included. So there are other classification as well as MIPS, that is Mutation Enhanced International Prognostic Scoring System, GIPS, that is Genetically Inspired International Prognostic Scoring System, but we usually use DIPS and DIPS plus sometimes. The adverse mutations are ASXL1, which is associated with decreased overall survival. TP53 is related to therapy resistance, and IDH1, 2 have more probability of transforming to AML. So next generation sequencing, that is NGS role, is required for comprehensive risk assessment. This is MIPS scoring, in which the variables are hemoglobin less than 10, peripheral blasts more than 2 or equal to 2, constitutional symptoms, absence of calreticulin type 1, high molecular risk mutations, or more than 2 high molecular risk mutations have 2 marks, and then unfavorable karyotype, that is 20q deletion, 13q deletion, trisomy 9, or deletion of Y chromosome, or other sex chromosome abnormality other than deletion Y. So how would we treat? NCCN guidelines say that low risk and high risk should be separated initially after diagnosis. In low risk, if there are no symptoms, then just observation or clinical trial. And if there are symptoms, then ruxolitinib is the drug of choice. Or you can use interferon or hydroxyurea if ruxolitinib is not available or not affordable. In high-risk patient, we should initially decide whether the patient is transplant candidate or not. If the patient is transplant candidate and has a donor, then allogenic hematopoietic stem cell transplant is preferred. Dr. Halisari very elaborately discussed the role of transplant in primary myelofibrosis. If the patient is not a candidate for transplant, then we should look at platelet count. If the platelet count is more than 50, yes, we can use ruxolitinib or second-line JAK2 inhibitor, that is fedratinib, or clinical trial. And if the platelet count is less than 50, then mostly the patients go for clinical trial. ELN guidelines say that you should see spleen size. If it is more than 10 centimeter, patient is intermediate 2 or high, ruxolitinib is drug of choice. Intermediate 1, if the patient is symptomatic, yes, ruxolitinib. And if the patient is not symptomatic, then first-line hydroxyurea can be given for cytoreduction, and second-line ruxolitinib. And in low-risk cases as well, for cytoreduction, we use hydroxyurea. Ruxolitinib is efficacious regardless of mutational status, whether it is high-risk molecular mutations or low-risk molecular mutation. In both the cases, ruxolitinib is equally efficacious. So you can see the response at 48 weeks by mutational status. Both low molecular risk mutations and high molecular risk mutation had the response in splenic regression and symptom regression. And survival probability is also equivalent in both low molecular risk as well as high molecular risk mutation. This is a very nice waterfall plot of COMFORT-1. JAK2 V617F allele burden decrease over time in ruxolitinib-treated patients, regardless of the baseline burden. So you can see that the patients who used ruxolitinib had a 50% reduction, and mean percentage change in JAK2 V617F allele burden from the baseline in COMFORT-1 after analysis of 3.5 years into 14 patients, ruxolitinib was more useful in reducing the allele burden as well. So a non-transplant approach to the management of myelofibrosis, our goal is to ameliorate, to avoid that the patient have increased symptoms, control the symptoms, control disease burdens, and constitutional and systemic symptoms should be controlled, and cytopenias should not be there. So if it is low risk or early asymptomatic myelofibrosis, sometimes observation is enough, and if there is increased cellular lines like leukocytosis or thrombocytosis, then hydroxyurea is required as cytoreductive therapy. In the case of constitutional symptoms or symptomatic splenomegaly, dragging sensation, JAK2 inhibition is required. So we have just ruxolitinib, but in America and Europe, you have second line, that is fedratinib, pacritinib, momelotinib. For thrombocytopenia patients, you can use fedratinib, pacritinib, and for anemia, momelotinib can be used. So anemia-directed therapy include erythropoietin-stimulating agent if the erythropoietin level is less than 500, and clinical trial with danazol and prednisolone are also done. We used to give thalidomide thalidomide or lenalidomide, lenalidomide with dexamethasone in those patients who respond, whose anemia responds to lenalidomide and dexamethasone. And whenever there is transformation to AML or we see increased blast, then hypomethylating agent, that is either cytidine or decitabine with venetoclax, is given to these patients. Transplant, yes, my favorite, but it is high reward but very high risk. There is transplant-related mortality, conditioning toxicity, high risk of GVHD. Then most of these patients come with large spleens. So there's a big question whether splenectomy should be done before transplant or it should not be done. So I think a splenectomy should be done, and there are now many trials with the myeloablative conditioning. JAK2 inhibitors are also being used along with our conditioning. So MANIFEST-2 update with plebaresib and ruxolitinib in JAK2 naive myelofibrosis. It resulted in splenic volume reduction that is more than 35% below the baseline size at 24 weeks, consistently higher with plebaresib and ruxolitinib across the key pre-specified subgroups, including DIPSS risk, primary and post-ATP-VMF. Baseline splenic volume, HP, and platelet count should be seen. We don't have this plebaresib, but if it is available, this is BET inhibitor. It is better to use it along with ruxolitinib. Then comes Transform-1 trial, in which the efficacy or safety of navitoclax, that is BCL2 inhibitor with ruxolitinib versus ruxolitinib with just placebo. So long-term safety and efficacy among 252 patients with 20.3 months follow-up was established, more than 80% with intermediate 2 risk and 50% with HMR, that is high molecular risk mutation. 63% of the patients with navitoclax and ruxolitinib achieved splenic size reduction less than 35% of the baseline, compared with 32% in placebo and ruxolitinib arm. So splenic size reduction, hemoglobin response, variant allele frequency reduction, and all these were achieved with this trial. And most common side effects were thrombocytopenia, anemia, diarrhea, and neutropenia. So the key highlights from the treatment, which was very extensively covered by Dr. Harris, and we have listened to the very experts, that is Professor Teferi, Professor Claire Harrison, about myelofibrosis. First line is ruxolitinib, and if the platelet count is less than 50,000, you can use pacritinib. Second line, fedratinib, and platelet count, if it is less than 50,000, you can use pacritinib. And for anemia, you can use momelotinib, and then it's supporting stimulating agent along with that. So I attended one of the lectures of Professor Harrison when she said fedratinib approved for the first line, but in my practice, I use it as a second line and ruxolitinib as a first line. So historically, treatment of myelofibrosis, anemia represented an unmet need. It is very difficult to treat anemia in these patients. Most of these patients are transfusion dependent, and it's very difficult for them to come twice or thrice a month for RCC transfusion. Prior treatment with steroids, erythropoietin stimulating agent, immunomodulatory drug, these agents had limited efficacy, and algorithms should now evolve to prioritize use of momelotinib if it is present. Definitely, why not? And we can tailor JAK2 inhibitors according to individual needs of the patients. If it is available, we don't have any other choice other than ruxolitinib. So we recently published Landscape of Somatic Mutations in Myeloproliferative Neoplasms in Pakistani Population in Pakistan Journal of Medical Sciences. We have more than 1,000 booked patients of MPN. However, for all these 1,000 patients, the Landscape of Somatic Mutation is not available. So in 2019 to 21, we took 159 patients, age ranged from 15 to 78 years with median age of 54. 38% of them had PV, 43% were primary myelofibrosis, and just 19% were ET. We were discussing that this increased number of primary myelofibrosis can be due to the fact that MF patients are more symptomatic. That's why they come to the clinics. So if you see the mutational profile in polycythemia vera, we found JAK2 V617F positivity in 85%. In 6.7% were JAK2 exon 12 positive, 5% were unmutated, and we could not extract the DNA due to different reasons in 3% of the patients. In ET, we had 51% JAK2 V617F positivity as reported in the literature. 17.2 were CALR positive, 28% were unmutated, and for just 3%, the same problem, DNA could not be extracted. And primary myelofibrosis, we had 34.5% JAK2 positivity, and CALR was found in just 9%, with 39% JAK2, CALR, and c-MYPL unmutated. These were the symptoms of these patients. Mostly the patients presented with weakness, abdominal discomfort, fever, bruising, and infections. Hepatomegaly was found in half of the patients. Splenomegaly and plethora were in few percentage. You can see management details that most of the patients were just given cytoreduction because they couldn't afford anything else. That is, JAK2 inhibition was given just for 5.7% of the patient, and mostly patients were or antiplatelet. So we could not find any significant factor in overall survival except that antiplatelet therapy. Those who did not use antiplatelet or not given or not taken due to any reason had lesser overall survival. So I would like to summarize that acquisition of driver mutation and expansion of the clone leads to development of myeloproliferative neoplasm, as all of us already know. Driver mutational profile is very important. It complements diagnostic approach to MPN. It is used for management decisions. It is used for monitoring and successful outcome of these patients. Availability of NGS panel is very limited in our country. It's just one institute which is offering NGS panel. It is very important for prognosis and disease progression. If we cannot have many institutes, we can train 2 to 3 institutes to have sample from all over the country and then do these NGS panel. I thank you all for your patient listening, and I'm happy to take any questions. Thank you.
Thank you, Dr. Mehreen. This was a fantastic presentation. I personally learned a lot of information from this. We have some questions in the question answer tab. So if you can please go there. There's a patient scenario. Somebody suggested a 50-year-old female who presented with thrombocytopenia with platelets in the range of 40 to 50,000. Bone marrow biopsy shows myelofibrosis. MPN panel is negative, and there is no hepatosplenomegaly. How will you manage this patient?
Sorry, there are many questions in the... so you are talking about which question? Okay. So the patient presented with hepatosplenomegaly, and there is increased myeloproliferation, but no mutational profile is there.
Right.
I couldn't get this question in the box. Can you repeat it for me, please?
Yeah, it's a 50-year-old female
Yes.
who presented with isolated thrombocytopenia. Platelet counts are around 50,000. Bone marrow shows myelofibrosis, but MPN panel is negative. There is no hepatosplenomegaly. So question is, how will you manage this patient?
I would like to see the bone marrow very carefully for excluding MDS in this patient. This can very well be fibrotic MDS. So it can be triple negative myelofibrosis as well, but usually myelofibrosis is with huge spleens and leukoerythroblastic blood picture, and teardrop shells should be present. So in this case specifically, I would like to have cytogenetics. I would like to have NGS panel. So to decide whether this patient is having fibrotic MDS or triple negative primary myelofibrosis. If this patient is transfusion dependent, then we will talk about transplant in this patient. If this patient is not transfusion dependent, we'll just observe this patient and follow her up in the clinic.
All right, great. So the next question we have is Dr. Akram is asking for low-risk cases of ET, but without CVD risk factors, but patient is having microvascular symptoms. Can we start cytoreduction if patient is not doing well on aspirin alone?
Normally, we don't start cytoreduction in the patients who are having low risk. However, if there is cardiovascular risk, yes, we can start on cytoreduction and we can follow the platelet count, we can follow the WBC count along with the low-dose aspirin. And sometimes if there's more cardiovascular risk, we can have twice daily aspirin as well.
Thank you. So there's the next question we have is that you are speaking of other clonal markers in the diagnostic criteria for myelofibrosis. And the question is, are these U2AF1, SRSF2, AASLX1, XL1? Are there any other specific marker to look for in a triple negative case of myelofibrosis?
Yeah, there is TP53 as well, U2F1, ASXL1, SFB3. And sometimes when we request for NGS, there are other markers which are reported as variants of undetermined significance, VUS. So if VUS has been reported, but in our population, this VUS is of significance, then it comes under consideration. However, internationally, other than these markers have not been included in clonal markers for primary myelofibrosis.
Okay, thank you. And then there's a question from the audience is that they want to look at your slide again, but I will suggest that, APNA Academy website actually hosts these recordings of lecture, which we make available within 2-3 days of the original lecture. And you can always register on the website, go to the slides, and you have a functionality of pausing the slide and reviewing the information. So instead of going back to the slide for an individual, at this point, I will keep going with the next question. And then Dr. Syed is asking, I have a TE patient treated with hydroxyurea who developed skin cancer in many sites, unfortunately. JAK2 inhibitors are indicated? Question mark. So I think they're asking about TE patient.
Yeah. So skin ulcers are very common with hydroxyurea, and whenever the patient has skin ulcers, we immediately omit hydroxyurea because continuation of hydroxyurea can cause enlargement of the ulcers, infections, and many problems. Yes, ruxolitinib is indicated. If the patient can afford to have ruxolitinib, we should start with ruxolitinib and omit hydroxyurea. And obviously, these skin ulcers can transform into skin cancers as well.
Right, thank you. So the next person is asking indications of cytoreduction in cases of secondary thrombocytosis.
I don't find any indication of cytoreduction in secondary thrombocytosis cases because they are just benign conditions. However, recently I've come across a case who was undergoing a CABG in a cardiology hospital, and the platelet counts, that was reactive, proven by everything reactive, but they were asking for hydroxyurea to reduce the platelet count temporarily in the peri-operative period. There is no indication of cytoreduction in reactive thrombocytosis.
Right, okay, thank you. The next question, can we give cytoreduction in congenital heart disease patients with symptomatic secondary polycythemia with hematocrit more than 70% and not comfortable with frequent phlebotomies for symptomatic raise in the hematocrit?
I've seen many patients of secondary polycythemia, and believe you me, even if the hematocrit is more than 54%, I have not seen them being symptomatic due to polycythemia. They are symptomatic due to congenital heart disease. So phlebotomy should be done. The cytoreduction is not very much indicated because for how long would it take cytoreduction? It's a congenital heart disease. Youngsters are coming. So phlebotomy, if they can keep the pace with phlebotomy, it is fine. However, if there is symptomatic iron deficiency anemia, then hydroxyurea can be considered if they are very much symptomatic due to polycythemia, secondary polycythemia. Otherwise, in our practice, we see the patients with 54%, 55% hematocrit, but they are not symptomatic. And even if you do phlebotomy twice a week or thrice a week, you cannot reduce their hematocrit level.
And I'm just scanning the chat to see if there's any question which did not address. I think one question came from Dr. Maktoum. What is the role of immunoglobulins in the management of cytopenias in myelofibrosis?
Immunoglobulin in the for treatment of cytopenias, we have never used. However, if the patients are having repeated infection, there is low immunoglobulin levels, IVIG is very, very expensive. So you can use it for repeated infections, but not for the cytopenias.
Right, thank you. There's another question, I think it just came now. Can cytoreduction be done in a patient with idiopathic polycythemia whose symptoms are not resolving with phlebotomies? Hematocrit is in the range of 52 to 55, but there are complaints of headaches and pain.
Yes, I think in such cases, we do use hydroxyurea. If by using every method, you use phlebotomy, everything, if the symptoms are not being controlled and it is idiopathic, and many of the idiopathic polycythemia have congenital reasons as well. We have a family of idiopathic polycythemia who had genetic mutations related to polycythemia. So you see, when you request for genetic mutations from international databases, there are so many mutations due to higher consanguineous marriages rates that they label them as VUS. But in our setup, those mutations are not variants of undetermined significance. They are significant. But since they have not been studied locally and they have not been included in the database, they are reported as VUS. So idiopathic polycythemia, if the hematocrit is more than 54% and the symptoms are more not relieved by phlebotomy, yes, hydroxyurea can be used.
Okay, thank you. Now there's another question. You shared a slide for a trial using ruxolitinib plus venetoclax rather than this. Can we use venetoclax in myelofibrosis plus ruxolitinib?
Navitoclax, it was Navitoclax. Another BCL2.
Yeah. Okay, right. Navitoclax, yes.
It was
You're right. Because they wrote Navitoclax and venetoclax, the same question. Yeah. What's the target hematocrit in idiopathic polycythemia?
In polycythemia vera, the target is less than 45%. We should keep the hematocrit less than 45%. And whenever it is more than 45% with cytoreduction, we ask for phlebotomy in this case.
I think there's a comment. I don't think it's a question. I would have liked to hear about some aspect of treatment using application of nanotechnology in the new era of nanomedicine. The lecture is very illustrative and enjoyable.
This is from Professor Noor Mohammed Bhatt. He is doing a lot in nanotechnology. My very dear uncle, a very close friend of my father, and his son is my classroom from KE. Thank you very much, uncle.
Wonderful. I think that was the only questions we could have. It's almost 10 o'clock, so once again, it was very good lecture for us to, I really enjoyed it and learned a lot. And thank you for your time and expertise and sharing your knowledge. We would love to have you come back and give us another talk in the future as well.
Thank you very much, Dr. Faiz. It was a pleasure to be at Apna's forum. Thank you very much. Allah Hafiz, and have a good evening.
Bye.